Previously, in the CNS Pharmacology Masterclass, we talked about the anti-epileptic drugs classification, and we mentioned that the anti-epileptic drugs are classified into the first-generation anti-epileptics, which are also called the classic anti-epileptics or the older anti-epileptics, and the second-generation anti-epileptics, which are also called the newer anti-epileptics. And the valproic acid is included in the first generation. Another examples of the first generation anti-epileptics include the phenytoin, the carbamazepine, the ethosuximide, the phenobarbital, and the benzodiazepines. Examples of the second generation include the vigabatrin, the lamotrigine, the topiramate, the levetiracetam, the gabapentin and pregabalin, and the tiagabine. So in our talk about the valproic acid, we will start with an overview. So a famous trade name for the valproic acid is the Debachin and the Convolex. This is the packaging of the Convolex, as you can see in this picture here. And the valproic acid is the greatest anti-epileptic drug to be discovered because it has the ability to treat most types of seizures, which the other epileptics cannot do. And the valproic acid is commonly mixed with the sodium valproate salt to improve its gastrointestinal tolerance by the patients. And the result is called divalproic sodium. And the divalproic sodium is what mostly used nowadays. Now, the valproic acid was first made in 1881 and came into medical use in 1962 after it was discovered by accident that it has an anti-epileptic effect. Moving on to talk about the mechanism of action of the valproic acid. Now, we can call it valproic acid or we can just call it valproate. So the valproate mechanism of action is not well understood yet, but possible theory may include that the valproic acid inhibits the voltage-gated sodium channels in the brain, and it also inhibits the GABA transaminase. Now, the GABA transaminase is an enzyme that has a function of breaking down the GABA. So when we inhibit the GABA transaminase, we actually stopping the breakdown of the GABA. So we have more GABA to work with in the brain. So inhibition of GABA transaminase leading to less breakdown of the GABA, thus more neuronal inhibition. Because remember, the GABA is a neurotransmitter that is involved in inhibition of the neurons. So more GABA means more neuronal inhibition. And the valproic acid also enhances the GABA synthesis. It also increases the synthesis of GABA since there is even more GABA, so there is more neuronal inhibition. And lastly, the valproic acid modulates the T-type calcium channels. And remember, the T-type calcium channels was related to the absence seizures. So when there is a problem in these channels, there is absence seizures. So the valproic acid also modulates these channels, so it also treats the absence seizures. Now, the variety of mechanisms that the valproic acid work with to stop the seizures gives this medication a broad spectrum of activity against seizures. Now let's talk about the therapeutic uses of the valproate. So we mentioned that it has a broad spectrum of anti-epileptic activity and it works on most types of seizures. So it can be used for myoclonic, atonic, and generalized onset tonic-clonic seizures. And it also can be used for absence seizures because of its ability to modulate the T-type calcium channels. Now, it is also effective in treatment of focal seizures, but it is not as effective as the carbamazepine or the phenytoin in treatment of that type of seizures. And the intravenous formulations of this medication used for the treatment of status epilepticus. Now, it is also used as a mood stabilizer for the bipolar disorder treatment, and it is used for migraine prophylaxis and for treatment of diabetic neuropathy and for treatment of schizophrenia. Now let's talk about the adverse effects of the valproate. So some adverse effects usually occur at the beginning of the valproate treatment, and they include nausea, vomiting, abdominal pain, heartburn, thrombocytopenia, tremor, insomnia, and depression. And those effects progressively become mild as the treatment goes on, and also lead to weight gain and increased appetite and hair loss, and those are common. Now, the valproate lead to hair loss, and that is the opposite to the phenytoin, which leads to hirsutism. Now, the valproate also may lead to severe adverse effects such as hepatotoxicity, Stevens-Johnson syndrome, psychosis, anaphylaxis, syndrome of inappropriate antidiuretic hormone secretion, pancreatitis, and aplastic anemia. But all of those are rare. And it is also teratogenic if given during pregnancy. It leads to orofacial and cardiovascular anomalies. It also leads to neural tube defects in form of spina bifida. Spina bifida is incomplete closing of the spinal cord during development, leading to the spinal cord popping out of the skin into the outside environment, like you can see in this picture here. And the risk for these anomalies are higher with valproate in comparison with other anti-epileptics. Now let's talk about the pharmacokinetics of the valproate. So it is available as oral and intravenous formulations, and the oral formulations are well absorbed with 85% bioavailability, and the food delays absorption, but the drug more tolerated if given after meals. Regarding distribution, the valproate is highly bound to plasma proteins by 90%, and the volume of distribution is 0.4 liter per kilogram. And since the volume of distribution is less than 10, this means that the valproic acid can be removed by dialysis during valproate toxicity. And the valproate is extensively metabolized by the liver through oxidation, glucuronidation, and conjugation. And the valproate is a weak inhibitor of the cytochrome B2C9 and the UGT and the epoxide hydrolase systems, meaning if there is a drug that is co-administered with the valproate and it was metabolized by the same enzymes that the valproate inhibit, then that drug would have higher levels in the plasma because its metabolism is inhibited by the valproate. And the valproate is eliminated through urine, and its half-life between 10 to 15 hours. Now let's talk about the drug interactions. So the valproic acid inhibits the metabolism of the phenobarbital and the ethosuximide because it inhibits some cytochrome B450 enzymes, leading to higher levels of these medications, and higher levels of the phenobarbital may lead to coma and respiratory depression, so it is important to know about that. And the valproic acid displaces the phenytoin from the plasma proteins, and this may lead to phenytoin toxicity. So if the valproate is co-administered with the phenytoin, you should pay attention to that. And it also decreases the clearance of the lamotrigine, leading to prolongation of the lamotrigine half-life. Regarding the contraindications, the valproate is contraindicated in significant hepatic impairment because it leads to hepatotoxicity, and the baseline liver function tests is mandatory to check for that before giving the valproate, and is also contraindicated in hypersensitivity reactions to the drug, and it is contraindicated in a pregnancy. Finally, let's talk about the valproic acid toxicity. So acute valproate toxicity manifests as central nervous system depression in form of drowsiness, confusion, ataxia, nystagmus, diplopia, dysarthria, tremor, and coma. So the patient might present with these symptoms, and the patient also may have metabolic acidosis, hypernatremia, hypoglycemia, hyperammonemia, hepatotoxicity, pancreatitis, and multi-organ failure. And the management of this toxicity is by stopping the valproate and supportive care, which includes fluid therapy and monitoring the vital signs and maintaining the airway patency, and also enhancement of elimination by hemodialysis, because remember, because of the low volume of distribution of this medication, it can be easily removed by the dialysis. So dialysis is always an option for treatment of toxicity with this medication. And with that, we reach the end of this video. Thank you guys for watching. Please support this video by giving it a like and commenting your ideas and questions. And this video is a part of a bigger class. It's called the Central Nervous System Pharmacology Masterclass. It will appear on your monitor right now. You can check it out.